blunt trauma abdomen, developed hemoperitoneum and came to us after 10 days of injury. Sir, patient was vitally unstable and was taken up for surgery. Intraoperatively, we found that there was bleeding from the liver, sir, which was packed, and sir, the blood was drained, sir.
मुझे लगता नहीं कि तुम भूमिका ज़्यादा बनाते हो, काम की बात नहीं कर रहे.
was a grade 3 liver injury.
Grade 3
Come to the point. How are you right? Just a blunt abdominal trauma, hemodynamically unstable, 10 days old injury, taken up for surgery. It was found to be having grade 3 liver injury, which was packed. That's it. Now you making a heavy weather out of it.
Injury of pancreatic head also, no? Pancreatic body. What was the
Yes.
finding?
What are the findings, Rishi?
So there was actually grade 4 liver injury, grade 2 splenic injury, and grade 2 pancreatic injury. So when they were in doubt, we kept the sum train in the lesser sat, and we came out. So sum train over the post-op period, we sent for amylase lipase. Since it was draining around 50 to 80 ml per 24 hours, the amylase lipase was found to be 70,000 and 80,000, which was kept expectantly. But however, over the few next days, it was accidentally removed. Patients further developed burst abdomen, and the next few days we found to have bile leak, frank bile leak from the right side. Further, MRCP was conducted and found to be intrahepatic biliary radical injury, just from where the previous laceration is. That's the status of the patient.
So now what should we do? How should we proceed?
He is on octreotide also.
What should we do next?
So we could always do ERCP and spectrophotomy to.
Basically, you need to have a distal passage clear.
Yes.
So basically, you can put in a stent after doing endoscopic peptidectomy. If you keep the distal passage clear, abnormal passage will stop automatically. This is what you need to do. And meanwhile, expectant management only. He's stable hemodynamically now.
Yes, sir.
And the fistula is controlled, or it's still.
Control.
There was no pancreatic duct injury.
No, sir. MPD, MRCP, there's no.
So if there is no MPD injury, if the duct is intact, then parenchymal leak stops after some time. So that's not going to be life-threatening. Even the duct can be, stented if there was, a leak from there. But MRCP was the investigation of choice. Putting on octreotide is a good idea, especially because of it being pancreatic fistula. But if it is dried up, it has no role. You should carry it on for long. Okay?
Yes.
What is an octreotide? Very good. Somatostatin analog. So therefore, we can start it in all patients where we suspect it to be a complex fistula. There is an element of duodenal or pancreatic.
He has bilateral tibial injury.
So in this case, if post-operative was found to be a major sectoral duct leak leading to this reason, so what could be options?
Two options. If it is a major sectoral duct leak and if the distal passage is clear, that is, you put in a good stent, and I'm talking about the covered stent, which can be directed to almost beyond it. That is, if you can do it. Otherwise, what you're hoping to hear is that we open up and ligate the duct. It's a very difficult thing to do.
Right.
Almost impossible to find it and ligate it. So it's messy. But that's a theoretical option that you have. The best treatment is still the same. Distal passage being made absolutely clear, using a covered stent to drain it adequately.
So is there a role of hepatectomy? It's a left-sided system.
If it is left-sided, yes. If it is a left-sided liver parenchyma, the good news is it will stop draining also after a while. So you may not require anything. It may actually necrose on its own and it will die off. The other option is you can go in and do a piecemeal, not an atypical resection.
Yes.
Piecemeal, and you ligate everything that comes your way. So it's more of a Kelly resection. You keep doing the Kelly and keep tying. Or you can use sealants. Easily.
So can we use more second generation somatostatin inhibitor, especially in case of trauma?
So please
like
understand the role of
serotype?
somatostatin is based on a very specific understanding. It's not applicable to all leaks. After some time, you cannot even give it. So you should be very selective in your use. Highly selective somatostatin, octreotides, somatostatin analogs, if they make any difference in the outcome, I don't really know. But I don't think they do. When there is a leak, distal passage has to be clear. One. Two, if it is persistent, it's like any fistula, it will need to be, the intervention is required. But after some time, eventually they all dry up. Very rarely would you like to go in and ligate this duct. And major sectoral duct is the reason when, in spite of putting in a stent, the patient is leaking. That is one reason which can continue to be a nuisance, because it is before even the stent is functioning, no? The leak is happening. It's like it is happening in Saket and your stent has gone up to Green Park. You can't take it there. So that will continue unless you block it. So this is what he was referring to. If it is a left-sided one, you can easily isolate it.
This one is a,
Left duct is longer also, you can even ligate it. There is no problem.
this one is a third patient. One more patient was.
That patient survived, you know. You remember that? We remember, always live to fight another day.
Yes, sir.
Always live to fight another day. Don't try to do everything. Your operation is great, but the patient has died. It's stupid. You've done an R0 resection, but patient is dead. No good news. And a negative laparotomy is better than a positive autopsy. Remember these three things. Always intervene when there is doubt. There is no shame. What can you do? Even if you opened up and if you don't find the duct, you can put the drain exactly where you want to, so that it drains optimally and it stops. Gradually it stops. So remember this. But one has to have a plan in mind. You shouldn't be crazy and berserk. ये अभी करना है तो अभी कर दी कुछ. You do something immediately, instantly. No. It should be driven by your scientific understanding of the problem and the scientific basis of the treatment. You shouldn't be illogical in your treatment.
Yes.
So there's nothing like a 007 kind of a surgeon. But you will, if I kill you with an AK-47, mosquito is on your forehead, I'm trying to kill it, who am I killing? You. The mosquito will fly anyway. Don't try to make a treatment worse than the disease. Treatment should be tailored to the problem, but importantly the patient.
Yes, sir. Thank you, sir. So he's a post-op case of re-exploration done.
You can go. You have the rounds go.
Done in a case of pancreaticoduodenal injury, which was primarily managed by bailout surgery, and then definitive surgery in the form of gastrojejunostomy was done. Currently,
No, actually, exclusion, diverticalization is done. Now the patient is fine.
Yes, sir.
And we did the triple tube. Subsequently, we've done exclusion and GJ. And patient is today's 15th post-op day,
Yes, sir.
post-op day, yes, sir.
and he's allowed orally and gradually go. That's
Yes.
it.